Dr. Mylad, thank you for joining us today.
Well, it's a pleasure. Thanks for having me.
Let's start off defining our terms. What exactly would you consider or are considered chronic gynecologic conditions?
Sure, yeah. This typically affects women starting with age around 13 or so, and typically goes through till menopause, around age 51. And the common conditions would be things like chronic pelvic pain as a result of things like endometriosis or other conditions, fibroids, abnormal bleeding. And those are sort of the typical symptoms, chronic conditions that are not cancerous, that affect women.
Now they affect women as you said, with severe pain, but also can affect reproductive systems as well.
Sure. So pain, bleeding, and infertility are kind of like the triad that potentially can be chronic conditions. Yeah, absolutely.
Now, I know that chronic conditions, a long time ago, a hysterectomy was, especially with endometriosis, hysterectomy was the only answer, and then they started bombarding it with massive doses of hormones. But are there any new alternatives and treatments that have been developed since then?
Well, yeah, we approach chronic pelvic pain and conditions like endometriosis in a multidisciplinary fashion. So I think that's the key. It's no longer just like a gynecologist anymore. Now it really requires like different disciplines. So, for example, in our office we have physical therapy. We have a physical medicine and rehab specialist who is an expert in what's called the pelvic floor. We have interventional radiology. So if the pain is from fibroids, we can treat them with what's called a embolization. And then, of course, we have doctors that are fellowship trained in minimally invasive gynecologic surgery that can offer hormonal, non-hormonal, non-surgical procedures, as well as conservative surgeries that don't require hysterectomy, and then obviously hysterectomy only if all else fails.
Now, and just to define terms again, when we're talking about hysterectomies, are we talking about complete removal of the system or even partial removals?
Sure, yeah. So yeah, hysterectomy sort of by definition means removing the uterus. Hysterectomy can be done as a partial, which means that you might leave the cervix, or a total, which is where we take out the uterus and the cervix. The cervix, of course, is the sort of like the mouth of the uterus, the part that sort of is attached to the vagina. Typically, when we do hysterectomies, we remove the fallopian tubes as well. Obviously, there's no reason to keep the fallopian tubes, and we think that by removing the tubes, it may lower their risk of ovarian cancer in the future. Surprisingly, removing the tubes seems to lower the risk of ovarian cancer. We almost always leave the ovaries, though, because leaving the ovaries means that woman won't become menopausal overnight. They won't experience what's called surgical menopause, and as a result, they would transition into menopause in a more typical fashion as opposed to sort of suddenly. But I think the take home here is that hysterectomy should be like the last possible therapy when pretty much everything else has failed.
And as you described earlier, it is the absolute last gasp, so to speak. Is there anything else we should know about hysterectomies?
Well, yeah, I mean, hysterectomies can be done in a number of different ways. The traditional approach has been to do it as an open surgery, and oftentimes we still have to do that. The trend has been now to do it as a minimally invasive surgery, so that's typically done with small or no incisions. We can do that laparoscopically, so that's done through the belly button. It can be done laparoscopically with robotic assistance, called the Da Vinci system, and nowadays there's a new robot system out. And it can also be done vaginally, which is kind of like the traditional minimally invasive procedure. Vaginal hysterectomy should be done by somebody, all of these should be done by people who are experienced. There's a lot of data to suggest that the number of procedures that a surgeon does correlates pretty directly with better outcomes. So if a surgeon is not doing more than, let's say, one a month, so at the minimum, a hysterectomy a month, then their outcomes are probably not quite as good as those that are doing more than that.
So do your research and find a physician or surgeon who is well versed in this. And things like the Da Vinci are becoming more and more common, even in smaller community hospitals now.
That's right. That's true. Yeah, even though they're, upwards beyond, like around $2 million, they're getting to be pretty common, and they're being applied to all kinds of different organs. Not just, they were originally, it was originally used in the pelvis for gynecologic procedures, and now urologic procedures like prostate and so on. But now they're being used pretty much everywhere. ENT, the heart, the lungs. So it's getting very common. And for gynecology in particular, the data is kind of mixed as far as does it really improve outcomes. Maybe in cancer patients, but in non-cancer patients, the data really isn't there yet. So if someone doesn't offer the robot, it doesn't mean it's any worse for hysterectomy or non-hysterectomy procedures.
Before we go any further, if somebody has questions about chronic conditions and about surgeries and alternatives, is there a website to go to?
Yeah, they'd be welcome to come to our Center for Comprehensive Gynecology website, which is here at Northwestern in Chicago, ccgyn.nm.org. So Center for Comprehensive Gynecology.nm.org. Yeah, they'd be welcome to. And they can also call 312-694-6447. As I said, we have this multidisciplinary team, and we try and make it like a one-stop shopping. They come in, they already have their imaging, they meet with a number of different providers, and then before they leave, we give them an opinion. We call it kind of like the one-stop shopping kind of thing, where all their questions are answered before they leave on the first visit.
And of course, being educated about your treatment is really the best defense and the best offense, for that matter.
Right, sure.
How long has the program been in effect? Is this long-term commitment from Northwestern?
Yeah, we opened 2 years ago, and Northwestern has prioritized women's health, so they put us up on the top floor of the newest building, and the whole floor is actually women's health. A third of it is for the fertility patients, a third is for our procedure room, and then the other third is for our center, this center specifically to address chronic, complex, non-cancerous conditions, such as fibroids, endometriosis, pelvic pain, ovarian cysts, as well as sexual medicine. So menopause and sexual medicine are also all contained in the same unit. So it's quite a priority, quite a commitment to women.
And it is the place to go for the most advanced treatments as well. And what do you see in the future? Where are we heading? Less and less surgeries, more and more alternative treatments?
I do. I think so. I think probably in the next year or so, we're going to have new drugs available. Women may be able to, let's say, for example, for fibroids, women may be able to go on these therapies intermittently to sort of keep fibroids in check and be able to sort of maintain their reproductive life, have their daily activities, be able to be intimate and not require a major surgical intervention. So I see that coming in the next couple of years where we're really able to manage these things medically or potentially surgically, but trying to avoid hysterectomy unless there's just no other option. And I think that's one of the take-homes is, first of all, patients need to sort of express what their priorities are. It's not just because they have fibroids doesn't mean they have to have a hysterectomy. What are their priorities? If it's not bothering them, leave them alone. There's no reason to intervene at all.
Right.
But if they have problems, then they should express what it is that they want. It's called shared decision making, and that's a critical part of effective healthcare. Is the patient is the center of these decisions, and not just the doctor sort of driving things.
And one more time, the places to go for more information about this and about Northwestern Gynecologic Surgery Program.
Sure. Yeah, the website is ccgyn.nm.org.
Very good. And with that, first thing, I'll thank you for giving us this information and for the work that you all are doing and the advances you're making. And we appreciate you taking the time today.
Bill, thank you for having me.